All right, good evening, friends from the Gujarat WhatsApp group, all those delegates who have joined today for this live webinar on pediatric nephrology part 2. As you would remember, we had done part 1 last month, and that was very well appreciated. And we couldn't finish the entire agenda, so we are now with the part 2. Today, I will like to thank the Zydus for giving us this platform to conduct this CME. And I would like to thank all the faculty. Of course, we'll introduce them again. Dr. Bajania will do it. But before that, I want to share some details with you. So I share my, you can see my screen, right?
Yes.
Yeah. So as I said, first of all, welcome to today's session. We started almost 4 months back with our first session on labs in hematology. And I'm very happy to say that we have already crossed 2,100 views on this Gujarat Pediatrician YouTube channel. So that speaks a lot about people's commitment to go and view and see these programs at least. So all these programs that we have done since then have been all archived on the Gujarat Pediatrician YouTube channel. You just type Gujarat Pediatrician and the channel will open in YouTube, and you can subscribe to it so that when the next video comes, you are actually given an alarm. After that, we had this on the TB with Dr. Varinder Singh, Dr. Yevle, and Sushant Mane. And again, we have more than 1,300 views. That was 3 months back. Then we did the JIA, the Joint is Angry session with none other than the maestro, Dr. Singh. And then we had our own other faculty, Suma Balan and Shikha. So we again that has crossed more than 1,000 view. And last month, as I said, we had this first part of nephrology. Morning it was 971, and now it has touched 999. So I'm sure by the time we end the session, it would touch 1,000. We had in between one vaccine session. Unfortunately, that vaccine session couldn't be put on the YouTube for almost 15 days because of some objection from the YouTube for something about copyright. So we had to take some time. So people viewed it while it was still live on the same platform that you are there today, that is a Steam. So that number we can't get it now, but I'm sure each one of them are becoming very popular. And this is the next month. We are going to have on 12th of September, again on the part 2 on vaccinology. Dr. Chetan Trivedi and Dr. Bajania will be the moderator. Dr. Kasi, Dr. Yevle, and either Dr. Jaideep or me. I mean, we are still trying to finalize. If Dr. Jaideep is unable to come, then I'll pitch in. Otherwise, Dr. Jaideep will join. And today we are here for the part 2 of the pediatric nephrology, as I said. So we have the same moderator, myself, Dr. Ramesh Bajania, and we have the same 3 panelists, Dr. Pankaj Deshpande, Dr. Sushmita Banerjee, and Dr. Fagun Shah. I will stop sharing my slides here, and over to you, Dr. Bajania, to introduce our panelists for today.
Yes. So as we know, this is part 2, and we have retained same panelist. And as Nitin Bhai said, that the part 1 was viewed by 999, and this doesn't count the people on Zoom platform live and other people live. I mean, there is some problem in counting. So we have an eminent panel of Dr. Pankaj Deshpande, is from Mumbai, Dr. Sushmita Banerjee from Kolkata, and Dr.
A little louder, Ramesh bhai, we can't hear you
Dr.
well.
Fagun Shah from Surat.
Yeah.
And when I went through the questions, I mean, I was so happy that Nitin Bhai has taken so much of pain. He has prepared 3 cases, and he has kept a common pediatrician, practicing pediatrician who faces such problems in day-to-day office practice. He has prepared the questions. So no detailed things as far as nephrology is concerned, but very useful things for common pediatrician. So Nitin Bhai, should we straight away?
Yeah, I think so. We should start with the first case. So you can start with the first case.
Yeah.
Little louder, Ramesh bhai. We can't hear you well.
Fagun bhai.
Yes.
Now, a 4-year-old male child comes with a history of puffiness and swelling of feet since 6 days. There is history of passing less urine since last 4 days. No fever, vomiting, sore throat, or pyoderma in recent past. On examination, child has puffiness, edema over the feet, blood pressure is 80/62, that is 75th centile for age. Now your thoughts? Because this is a very common presentation in for general pediatricians.
Yes, so basically, I think so. All pediatricians over here, they
Magun bhai,
basically
your
know.
voice is breaking again.
Again,
I think you
breaking.
need to remove the AirPod. Yeah, yeah,
Yes,
yeah.
Fagun bhai.
Try without that. No, you are much. Yeah, go ahead.
Hello, is it
Yeah, yeah,
audible
we are,
now?
you are audible. Yes, yes, perfect.
Now is it okay?
Yeah, yeah.
Yeah. So I think so that all the pediatricians over here are very much well aware of this very common presentation which we get. So here there is a patient who is having the edema of the feet and puffiness of the face, and otherwise the child is absolutely fine and there is no hypertension. So we all know what we are dealing with. But again, coming to the case, we all know that this is a renal edema, and this renal edema is probably because of the glomerular pathology. So when we talk about the glomerular pathology, two things which we commonly deal with in our practice is one is a nephrotic syndrome, and second very important thing is a acute glomerulonephritis. Most commonly we deal with a post-infectious glomerulonephritis, and many a times we are quite confused because there is lot of overlap between these two things. So it is very important to differentiate depending upon the clinical features, that is symptomatology as far as the examination. So here we have the puffiness of the face, and or we can generalize edema. So what is the difference between the edema in these two conditions? In the patients with the nephrotic syndrome, probably it is because of a third spacing which is occurring, and hence it is a dependent edema which keeps on fluctuating. While the patients who are having a post-infectious glomerulonephritis, it is basically a decreased GFR which is leading to the volume overload, and hence the edema is quite static. So these patients will always have an hypertension, while nephrotic syndrome, the hypertension is very rare to occur. And as Ramesh Bhai pointed out that the child is not having any vomiting, fever or upper respiratory infection pyoderma. So this is important because the patients in the post-infectious GN, we need to elicit that whether there is any history of intercurrent illness in the last 1 or 2 weeks, because that will always point out towards the post-infectious GN. Nevertheless, the patient with the nephrotic syndrome, the first episode can also be precipitated with that. And finally, the color of the urine. So probably here the color of the urine is normal, which I expect or which I presume. So this patient probably is a case of nephrotic syndrome, and we need to confirm it with the urine investigation as well as the biochemical test.
So, Fagun bhai, urine shows 4 plus protein, RBC is 2 to 4 per high power field, WBC 6 to 8. Thoughts?
So the urine albumin is +4, which is a heavy protein urea, which indicates that it is more than about 1000 milligram per deciliter, and there is no RBCs in the urine. WBCs are 6 to 8, which can be significant, but here it is probably because of the glomerular pathology and not because of the UTI. And coupled with this, if we do a biochemical investigation and with this history, probably we'll be able to diagnose the case as a nephrotic syndrome.
Right. Now, role of 24-hour urinary protein, because we used to do in our C to what versus spot protein creatinine ratio.
So actually, if we take particular this case, then if the patient is having this clinical symptomatology and the urine albumin is +4, along with this, if your biochemical investigations are supportive, we might not need to go for a quantitative estimation, that is a 24-hour urinary protein or a protein create ratio. But if you want to really confirm, we definitely need to quantify the amount of protein. So there are two ways. Either we go for a 24-hour urinary protein or we go for a protein creatinine ratio. Now, really what we are looking at or what we need to diagnose is a nephrotic range proteinuria. In adults, where we have a proteinuria in different conditions, glomerular conditions like membranous nephropathy, MPGN, or we have IgA nephropathy, here the amount of protein is very, very important. That is how much the excretion is occurring, 500 grams, 1 gram, etc., because the treatment depends upon that. But in the nephrotic syndrome in pediatric patients, we just need to know what is the degree of proteinuria, whether it's in a nephrotic range. 24-hour, we all know more than 1 gram per meter square per 24 hours is basically per 24 hours is basically a nephrotic range proteinuria. But it is quite cumbersome to collect in the pediatric patients. So here we can go for a protein creatinine ratio. And a protein creatinine ratio is a simple test which can be done in a random sample. More useful if it can be done in the morning, first sample, and a ratio of more than 2 straight away says that the patient is having a nephrotic range proteinuria. It doesn't define or it confirms the proteinuria or nephrotic syndrome. We can just say that it is a nephrotic range proteinuria, which is an important and essential criteria for the diagnosis of a nephrotic syndrome.
Okay. Now, can it be so that urine protein be trace and still this protein creatinine ratio is high?
Yes, I think so. We just pointed out in the last time when we were talking about the urine microscopy examination that there could be false negative as well as false positive protein in the urine. So it all depends upon what is the pH of the urine or whether the urine is dilute. Acidic urine or very dilute urine, specific gravity less than 1.010, etc., might lead to a false negative result. So in case sometimes it might happen that the child might be edematous, you have given the diuretics and the urine is very very dilute, and at that point your urine albumin is negative, so you might just wonder that what is happening. The child is having edema and the urine albumin is negative, so you need to confirm at that point of time with the protein creatinine ratio, which will be definitely higher.
Now, which are the other causes of proteinuria, and when you will call that this is due to nephrotic syndrome?
Proteinuria, if we broadly define or divide, there are 4 or 5 categories. One is basically what we have is a transient proteinuria, which we find in fever or infections or your dehydration, etc. Then the most important category is the glomerular category or a glomerular proteinuria, when there is a loss of lot of amount of proteins because of the change in the or leaky basement membranes. Here the protein is mainly albumin, and it could occur because of the all list of the glomerular conditions, including lupus or IgA, NS, and etc. The third category is your tubular proteinuria, in which there is a loss of the tubular proteins, that is the alpha 2 microglobulins, etc. But the most important is or it could be because of the plasma proteins. So when we talk about the nephrotic syndrome, we need to have 3 or 4 criteria for the diagnosis. One is there should be an edema. Number two, there should be an hypoalbuminemia. And mind well, latest guidelines have changed the criteria or cut down of the protein level. So initially in the old criteria it was 2.5, but now it is less than 3 gram per dl, so it is a cut down limit. And the third important criteria is a nephrotic range proteinuria, as I mentioned, that the protein create ratio should be more than 2. So these are the 3 essential criteria. High cholesterol or hypercholesteremia was initially considered as an important criteria, but nowadays or in the latest guidelines it could be one of the criteria, but it is not an essential criteria.
So further, any other biochemical test apart from this?
So in a straightforward case of nephrotic syndrome, I will just like to do 3 tests apart from the urine, or 4 tests. One is you need to know the renal functions. So you do a creatinine electrolytes, you look for the cholesterol, you look for the serum albumin, and you do at least in a first time, the first episode of nephrotic syndrome, you do a ultrasound to look at the kidneys, whether they are okay or there are any structural issues in the kidney. So all these 4 tests probably will give you a diagnosis of a nephrotic syndrome.
All right. So Fagun bhai, here in this patient, proteins were 5 gram, albumin was 1.3 gram, globulin was 3.7 gram, cholesterol was 300 milligram, blood urea nitrogen was 25, creatinine was 0.6, and sodium was 142, potassium was 4.1.
Yeah, so it is a straightforward case. Normal lights, normal creatinine. We have a high cholesterol and a low albumin. So this is a classical case of a nephrotic syndrome, supported by all your biochemical investigations as well as your urine microscopy as well.
Fine. Now, is there any role of urine culture and MT XRC or?
Why do you want to do a urine culture over here?
So
This
no.
straightforward case of nephrotic. No urine culture is required. This is not and the child is not having any urinary symptoms, fever, etc. So no need of doing a urine culture. And in fact, urine culture should not come in the list for the diagnosis of the nephrotic syndrome at all.
Okay. Now, the most common puzzle for a practicing pediatrician, how do you know that it is minimal chain nephrotic syndrome and no other varieties at this point of time?
So just before that,
So
Fagun bhai, the
Yes.
other part of that question was that do you rule out active tuberculosis as a
Yes.
screening in all these children because they are likely to be on steroids? So do you
yeah,
always
so
do it or only if they are symptomatic?
So actually, the things are different. What I do and what the guidelines say. So I have little bit reservations as far as doing the MT and X-ray are concerned, and I will always, in the patients who are having high risk factors, I will go for a MT test. But what the guideline says is that because the chances of the latent infection or the prevalence or incidence of latent infection in India is very high, you at least do an MT. And if the MT is positive, you do an X-ray test and see how it is. If the X-ray test suggests you, then you can treat accordingly. And if only MT is positive and X-ray test is normal, then you give this your tuberculosis drugs. This isoniazid for 6 months. But again, I think 2 things are very, very important over here. When you are giving isoniazid, what they say is that you have to prolong the treatment or you defer the treatment for at least a week, 10 days. Now, the patient, if are not given steroids immediately, they become very, very moribund. The edema increases profusely. And number 2 is this, that all these drugs are inducers of the hepatic enzymes, and sometimes the response to the treatment, that is your steroid response, is quite becomes suboptimal and the child suffer a lot. So that is for this reason, as simple as this, that I will have my reservations. And most of the times, if there are some risk factors, positive contact in the family, etc., then it is prudent to go for this. But the guidelines definitely say you need to do an MT.
So now Mantoux test is not available because the standard Mantoux reagent is no more available in the country or in the world. So if you look at the IAP, tuberculosis guideline, NTP guideline, they so Mantoux is not mentioned. So it's either X-ray chest, contact, AFB, etc. for an active disease or an IGRA like test to see for latent TB. So you do an IGRA if there is suppose contact or recent contacts in last 2 years, or would you just do an X-ray if it's okay, just start steroids? This is a practical question because the children are going to be on steroids for a very long time.
Yeah, so as I told you that most of the times, if there is a positive family history, or there is a history of contact, or if there are some suggestive symptoms, definitely you can do an X-ray test and see and go for the further investigations if the X-ray test suggests you. But if the child is straightforward case, if there is no family history, I mean, out of the blue, there is no need to go for an X-ray test, etc. Because you will burden the child, because there are sometimes some opacities, etc. here and there, and then there is a lot of confusion whether to start AKT or not. And once you start AKT, again you delay the steroids, and then the child becomes more and more moribund, accumulating the edema.
No, but that's no reason why you would not investigate in a child who is suspected to be, because if you
No, if you
turn a
suspect,
blind eye,
no,
so
if you're
that's the question.
yeah, so if you're suspecting, if there is a positive family history, if there is an history of contact, etc., and if the child is coming from that area, definitely you will need to investigate for that AKT. And definitely, if it is there, you will use AKT, defer the steroids for initially treatment for about 2 weeks, and then start AKT, and then start steroids once you have an effect of your AKT.
Okay, also let's hear from Pankaj and Sushmita what they do. Every new nephrotic do screen for tuberculosis in a country like us. First Pankaj, then Sushmita.
No, unless they are symptomatic, there's no point in screening.
Perfect. And Sushmita?
I would say the same. So it
Okay.
depends on which socio-economic status
Correct.
they're coming from, contact history,
Correct. So
etc.
I think the NTP guideline also are very clear that do not investigate for TB unless you're suspecting, and you suspecting is clinical, which is cough for more than 2 weeks, weight loss or not putting on weight in spite of no other primary reason, and a history of COX contact. And with these three are there, then you investigate. I think that is a very
Absolutely.
valid point, even for patients who have nephrotic syndrome.
Correct.
Dr. Vasudev,
Nitin,
quickly,
can I make a
yes.
small comment?
Yeah,
Yeah,
quickly,
What
yes.
we had talked about these guidelines quite at length, and Dr. Sushmita would remember at Calcutta, we had a brainstorming session, and almost everyone agreed that in a country like ours, where the family history sometimes may be missing, or they may be hiding the family history, and the child is going to go on steroids, there's no harm in getting an X-ray chest done and rule out if there's any lesion. If there is not, then we don't need to go for IGRA and other tests. But if in absence of MAN2, at least get an X-ray test done. That's what we are doing in our setup in at least Delhi. A lot of tuberculosis around we see in UP and coming from other areas. So we cannot ignore that part. Thank you.
But those where you found that they had ultimately they were proven to have TB on X-ray chest, Dr. Vasudev, they were asymptomatic or they were symptomatic, right?
You see,
Besides nephrotic.
weight loss sometimes is not very evident because they are gaining weight. They are edemators. They may be in fact gaining weight. So
But
we
cough,
cannot take the history of
persistent cough and or fever.
cough. Probably in younger children, it may not be one of the symptoms of tuberculosis, but family history and if there are other telltales, but at least an X-ray rules out there's no active lesion and safe to start steroids in today's time. If we start steroids without getting a baseline investigations, it may be causing sometimes a medical legal issues also. And at times we have picked up cases where there was no history. The X-ray was suspicious. We got an IGRA, got a consultation from Dr. Ankit Parekh or Virender, and they started on ATT. And even if you have to start ATT, we can start steroids after a week. In the meantime, the edema can be controlled with diuretics, and that is not an urgency to start steroids. So I think we have to play a little safe when we are starting steroids and giving it for months and months for these children.
Okay, fine. That's a differing point of view that he would probably do an X-ray. There's no harm in doing an X-ray. Okay, go ahead, Dr. Ramesh.
Yes. Now, Fagun bhai, we have very two common conditions as far as nephrology is concerned, nephritis and nephrotic syndrome. And plus, there were this confusing word, nephritic onset of nephrotic syndrome. I mean,
Sir,
as
you
a
had one
resident,
more question initially also. Before that, you were asking something, minimal change disease, and some question was
yeah.
that.
How can you know that it is minimal change nephrotic syndrome and not
Okay.
other varieties?
Okay. So basically, if you look at the the nephrotic syndrome, 90% of them are basically in idiopathic nephrotic syndrome. And in the idiopathic nephrotic syndrome, about 80-90% are basically your minimal change. And next 10 to 15% could be your FSGS, mesenteric pleural fluid, etc. And if you take into consideration your minimal change, again, 90% of them are steroid sensitive. So if you pick any case, say for example, 100 cases, about 80-85% of the cases are basically minimal change and majority of them are steroid sensitive. So a patient who is having a straightforward case, 2 to 8 years of the age group, proteinuria, no hematuria, no hypertension, normal renal functions, and who was steroid sensitive, probably you are dealing only with a minimal change. But any deviation from that, say the child is a steroid resistant case, or if there is a low-grade microscopic hematuria which is persisting, there is an hypertension, there might be slight alteration in the renal functions, you must think out of the box, and there could be some other conditions which could also be a cause of the nephrotic syndrome.
Because
Can I
this
just
is such a
can I
yes,
just
yes,
add in here?
yes, please.
Just one
Yes.
point. Yeah,
Yes.
just two things to add. One, minimal change is a biopsy diagnosis.
Correct.
So you can't say, no, I'm not telling Fagun, I'm telling Ramesh.
Yeah.
Yeah.
You can't say the child has minimal change. We can say steroid sensitive or steroid resistant. The second thing is, as he rightly said, minimal change, usually steroid sensitive. Now, there is a clinical way to differentiate between these two. Usually, minimal change or steroid sensitive will have an explosive onset of edema. So, which means that the parents will remember exactly 12 दिन पहले, 10 दिन पहले सूजन शुरू हुआ. If you have got an insidious onset of edema, it is more likely to be one of the other varieties. So
Perfect.
it's just a
Perfect.
clinical feature.
Perfect.
Perfect.
So the other question was that what is nephritic onset of nephrotic syndrome, Fagun?
So as such, the nephritic onset of the nephrotic syndrome is the point which we have termed in our residence, and basically we use it very commonly during the residency days. So here there is a nephrotic syndrome. We have all the features, and superimposed on that, we also have the features of the nephritic syndrome, like the child will be hypertensive, edematous, or there could be a decrease GFR, that is a raise in the creatinine, hyperkalemia, there will be a toxic look, there would be a red urine, etc. So these are the patients in whom the diagnosis might not be straightforward. You might be dealing with an alternative diagnosis, like the patient might be an MPGN or C3 glomerulopathy, membranous nephritis, lupus, etc. So these are the patients which you need to pick up, and these are the patients which needs to be sent urgently or immediately to the nephrologist, because these children will require biopsy and other special investigations and a special treatment, and not the classical or weekend treatment for the nephrotic syndrome. This is one of the red flag sign. Okay.
Okay, fine.
I think now
Now-
some rapid
yes.
fires, Fagun Bhai,
Yes.
for the treatment of the first nephrotic syndrome. Dr. Ramesh, go ahead.
Yeah. So everyone knows that steroid, but which steroid and
It's a
dose, duration,
prednisolone.
how
So
do
it is
taper? Just
prednisolone. Prednisolone without any doubt. No other steroids have to be used.
2 mg per kg.
2, yes. So if you like to dose is, so you can just give the dose depending upon your body surface area or depending upon your weight. So 2 milligram per kg per day is basically the weight. As per the weight, if you want to go with the body surface area, 60 milligram per meter square. But remember, it should not exceed 60 milligrams. That is, a 50 kg child cannot get 100 milligram. Upper ceiling is always a 60 milligram, and when you give it on an alternate day, the upper ceiling is always a 40 milligrams. So alternate day dose is 1.5 milligram per kg, alternate day single morning dose. So the duration is that when you give a full dose, the first episode, 2 milligram per kg per day, not to exceed 60 milligrams in a single dose or a divided dose for 6 weeks. And if the patient is in remission, shift to alternate day, 1.5 milligram per kg, single morning dose, not to exceed 40 milligram. And this has to be given for six weeks and stop abruptly. No tapering is entertained.
Okay. Now, any role of antacids or calcium, vitamin D, or tradition of giving with milk? What
So
we used to
basically,
advise?
yeah, so steroids are gastric irritants, and this gastric irritant is better to be given after any meal. So in the morning, if you are giving after, then you give after breakfast. As far as the milk is concerned, there is a tradition of giving any medicine with the milk, because it is believed that it reduces the gastric irritation or the side effects, and hence there is no problem giving it with the milk. As far as the antacids are concerned, our children tolerate these drugs very nicely. So it is illogical, or there is not, or it is not necessary to bombard the children with extra medicines. Except and unless and until if the child is suffering from or having this gastritis, then you can add on. While what else, and what next? Which other
Calcium and
drugs?
vitamin D.
Calcium and vitamin D for the first episode, you are just giving for 3 months. There is no need. If you are having a steroid-resistant nephrotic syndrome in which there is a proteinuria continuing, there will be loss of vitamin D binding proteins, etc., and there is osteoporosis, you will definitely need to add that, but not in the first episode. Just give steroids. That is it.
Okay,
Calcium?
fine. Now, how do you monitor
Calcium,
blood pressure?
calcium.
No calcium due to you are giving just for you are just giving for 3 months. So if the patient is having frequent relapsing nephrotic syndrome or dependent, when you are, the steroids has to be continued for a prolonged time, definitely you can add it.
Okay. Now, how do you monitor blood pressure, urine, serum protein, and how frequently? This is it.
The best monitors are basically our parents. So you need to teach all the parents to do a urine albumin at home, either by dipstick or by a heat method, and they will tell you how the things are. So when you are having a first episode of nephrotic syndrome, the child is edematous, you are not admitting, and you are giving steroids always as well as the diuretics, it is prudent to call the child maybe a day or on an alternate day, because you never know when the child will go into remission. And once they go into remission on diuretics, there could be profuse polyuria and there could be loss of weight, significant amount of weight just in a day or two, ending up with significant dyslipidemia as well as the weight loss and hypertension. But once the child is stable and there is no edema, the child's parents can monitor the urine at home. And if the urine is negative for 3 consecutive days, they can come to you and you can confirm it with the protein creatinine ratio and continue the steroids as per the regime. Also, it is very important to see the parents or to see the child whenever you are changing the medications, and at least 2 to 3 weeks after the medications are changed, because these are the time when the relapse could occur. As far as the home monitoring is concerned, if the child is in remission, the parents can do a urine dipstick every alternate day. And on infection, so basically whenever there is infection, it is prudent to check the urine at least for 2 3 days continuously. Or if there is a proteinuria, they can check for 2 or 3 days continuously, and if it is persistently present, then they can report it to you. As far as the hypertension is concerned or BP is concerned, every visit you need to check the BP. What else? Is there anything else? And there is no need to do any other biochemical investigations.
Serum proteins, no.
Serum proteins, no, there is no need to do any biochemical investigation.
Fine. And how do you know that patient is in remission? And second, what if patient doesn't go in remission by at the end of 6 weeks?
So remission, we have either a clinical remission or a biochemical remission. So clinical remission is the first to occur, the biochemical remission which will follow. In the patients who are having a clinical remission, as I said before, the child will have a profuse polyuria. The weight will be reduced in just 1 or 2 days, and the child will be absolutely dry and emaciated. And this has to be confirmed by the urine albumin for 3 days, and you can also confirm it with the protein creatinine ratio. Okay. There is no need to check for your cholesterol or albumin because it might take some time. So if this is present, your child is in remission. However, if the child doesn't go into remission by 6 weeks, don't just jump directly to label it as a steroid-resistant nephrotic syndrome. There are two things which are very, very important over here. First of all, check the compliance. The compliance has to be checked, whether the child has taken or the parents have given the drugs properly or not. If there are child is compliant, just ask whether the child had any intercurrent infection in the last week or 7 days. Because if there had been some infections, then it is possible that the child might have a proteinuria. So a child who has taken the drugs properly and no infections in the last 5 to 7 days, and if the child has not responded to steroid by 6 weeks, then you can label them as a steroid-resistant nephrotic syndrome.
Okay. And Fagunbhai, any correlation of days to remission with long-term outcome?
So if you consider the remission time, most of the patients will 70% or other will go into remission by around 10 to 14 days, and remaining 20% by around say 4 weeks or so. So if majority of these patients will have a remission by 2 weeks. So if the child is not having any remission by 2 weeks, or if the remission occurs late by around 3 weeks, 4 weeks, or 5 weeks, then it is considered as a delayed steroid response. And these are the patients, various studies have shown that these are the patients who might have a protracted course, might have a frequent relapsing course or a dependent course.
And risk of AVN, long-term complications like cataract?
As far as AVN is concerned, definitely long-term steroids causes AVN, but in fact, in my practice of last 18 years, I have not seen any AVN, but definitely we see many other side effects and which are very, very important. One, the most important of them being cataracts or the raised IOP, psychosis, myopathies, and the most important is the obesity, short stature, as well as the impaired glucose tolerance. So all the patients who are in the prolonged course of the steroids for dependency or for resistant, you need to check very periodically for all these complications as well. And it is for this reason that the use of steroid sparing agents has to be used more avidly if the steroids have to be given for a prolonged time.
Okay, now let's move the gear, and I
Thank you,
take to
Fagunbhai.
Pankaj. We have very lucidly elucidated the management of the first nephrotic syndrome, which will be 9 out of 10 times, as what Dr. Fagun said, and that's the end of it. But it is not that the patient has responded, the steroids are stopped, and everything is okay. You need to follow up the child for a very long time. So, Pankaj, patient is now in remission and off steroids. Now, how do you monitor for the relapse and how frequently? Like you do this home testing or a laboratory testing once a week, once a month? What is it?
Correct. So I think just give me 2 minutes here. The first thing is when you say a relapse occurs only after you've gone into remission.
Correct.
So just picking up the point that Fagun said, don't rely only on the dipstick. Get a urine protein creatinine ratio done at 4 weeks. Because I've had several steroid-resistant nephrotic syndrome where they have gone into clinical remission. The dipstick shows 1+, but they are steroid-resistant and they keep on getting steroids for 2 or 3 years without going into remission. So that's the first thing. The second thing is we need to disconnect relapse and edema, because one of the advice that is usually given is do your urine stick or the urine test whenever there is edema. That has absolutely no meaning, because unless you accumulate 2.5% of your body weight in the third spaces, you will not be able to demonstrate edema.
Perfect.
So that is why edema is not a feature, it is the proteinuria part. And often they will have proteinuria first and then the edema comes quite a bit later. Just a clinical pointer for anybody who's dealing with nephrotic syndrome, whether they present the first time or in a relapse. Often parents are very geared to looking at edema. So if they complain of edema below the eyes, it's very often not a relapse or not nephrotic syndrome. When the edema is above the eyes, it's often nephrotic syndrome. It turns out to be nephrotic syndrome. Below the eyes, it's often because the child has not slept, has got a viral URTI, too much mobile, too much screen, and all those kind of things. Now, coming to actually monitoring, you can do a dipstick, which is quite easy to do at home. Once a week, the relapses, the number of relapses that the child is going to get is going to be determined in the first 6 months to 1 year. So they need to check it at least once a week for the first 6 months to 1 year. And then if we are sure the child is not getting relapses, you can relax the time and probably make it once in 2 weeks or once in a month.
So when will you say that this urine dipstick is, say, showing protein 2+? They do it daily for the next 3-4 days to see whether it's increasing in quantity, to say that now you need the protein creatinine ratio, or at any 2+ you would ask for a protein creatinine ratio?
No, I think you need to first check if there is an infection present, because if you have an infection, if you have fever, if you have URTI, it's very likely you are going to have protein. So the way to deal with it is either you wait for 3 to 5 days, see whether the protein disappears, and then continue, or there's another category of thought which says that if you have finished your steroids, then you can give 0.5 milligram per kilogram of prednisolone for 5 to 7 days and recheck the protein. So if it goes away, then it's unlikely to be a relapse, and then you can just make it alternate and stop it.
None of this scenario is there, but the urine protein is 2+ at 3 months of follow. Now, how do you counsel the
once you've
parents?
finished the
3 months are over, he's off steroid, but now parents say this Sunday it was 2+.
Correct. So you recheck it after 3 to 4 days, and if it is still 2+, then it's very likely to be a relapse. If it is 1+ and you're not sure what is happening, then get a protein creatinine ratio.
Perfect. All right. Now this patient comes back 4 months later saying the child had fever and cough for 4 days and the urine dipstick was showing 2+. Now, what next? You treat the infection, or you treat with 0.5 mg per kg of steroids, or you do both, or you do none?
Okay. See, the first thing is it may or may not be a relapse just because you've got protein, because there is infection that is present. So you treat the infection. Be careful, don't give antibiotics every time, because I think that's what antibiotic stewardship is all about. If it is viral, then you treat it as a viral, because if you give antibiotic, the parents start thinking that antibiotic made the relapse go away, and they will use antibiotics on their own. So I think you treat the infection and wait for 5 days. If the protein goes away, it's fine.
So one question, that if suppose the child has the URI like picture and protein became 2+, if you do the protein creatinine ratio, is always above 2 that time, or it is between 1 and 2, or it is just above 0.2? What is the usual pattern in infection related vis-a-vis a relapse?
It can be anything.
It can be even more 2.
Yes.
It could be nephrotic range.
Yes.
But it would disappear in 4-5 days time after the infection. All right. Now this child has come back with dipstick 2+. Now it's becoming 3+. He does a protein creatinine ratio is 4.6. So this is a relapse, correct?
Yes.
So how do you treat the first relapse and how to treat the subsequent relapses?
Right. So the first relapse, you will restart on 60 milligram per meter square daily of prednisolone, like you did for the first episode.
Correct.
But this time you would give it only till the urine dipstick becomes negative for 3 days.
Correct. And
After that, you taper it down and make it 40 milligram per meter square alternate day for 4 weeks. And then you can stop it if it's the first relapse. If it's subsequent relapses, then you can attempt to taper it down further from 40 rather than stopping it abruptly and come down to a dose of 0.5 or 1 milligram per kilogram per day.
So still you will give for how long maximum?
No, the first one, so you have given,
No,
let's say,
first one you said, suppose
Yeah.
you're worried about.
yeah, so once you start tapering it down, if the child keeps on relapsing, then he falls into the category of frequent relapses. So you will have to
Correct.
start using some other agent, which
Correct.
will help the steroids.
Correct. And while we have given the steroid till the time is 3 days proteinuria negative and then switch to 40 on alternate day.
Correct.
Again, the monitoring would be the same as in the first episode, or monitoring would be a little more frequent or less frequent?
No, I think once a week is more than enough to
Correct.
monitor.
Okay. And so a child who has got frequent relapses, now do you do a only still urine dipstick, or you often do protein creatinine ratio to pick up an early relapse?
No, I think if your dipstick is showing 2+ or more in the normal circumstances and it is present for 3 days, you don't need a protein creatinine
Correct.
ratio
Correct.
to
So
diagnose a relapse. Yeah.
correct. Can they cut the strip of protein the dipstick to use it 2 times instead of 1 time, or does it damage the pad where the reagents
Depends on what kind of scissor you use. And as long as it is not exposed to other things outside, yes, you could use it.
You could do it, huh? Okay. I was told that once you cut it, the pad gets exposed to air.
It's not advisable.
It's not advised.
Not
Okay.
advisable.
But an Indian jugaad is okay.
Well, if you are short of money, anything is okay.
All right. So you said frequent relapse. So by definition, what is frequent relapse?
So frequent relapses is more than 2 or more in 6 months or more than 3 in a year. It's called as frequent relapse.
And then how do you treat them? You treat them differently or treat them the same way as the first relapse?
So if they start having frequent relapses, the steroid course will remain the same. You will give 60 milligram per meter square daily till they go into remission, but you'll do a slow tapering of the steroids, but you will start adding other agents once you start realizing that the child has got frequent relapses.
When we were students, we were taught to use levamisole in such a condition. Is it still a drug which is a good immunomodulator, or is fallen out of vogue with these so many monoclonal antibodies and other things which are coming in the way?
No, I think levamisole is a wonderful drug. As I showed you in my paper, that if you use it judiciously in proper patients, so if the child has gone into remission in the first episode within 10 days, and if they have less than 6 relapses in a year, there are 80% chances that they will respond to levamisole brilliantly.
So what dose?
2.5 milligram per kilogram.
And twice a week, once a week?
No, alternate day.
Alternate days. And how long you give? 1 year, 6 months?
2 to 2.5 years. So if they've not had any relapses for 18 months, you can consider stopping it. Otherwise, continue for 2.5 years.
And it's a myelotoxic drug, right? So do you monitor for counts and things like that? So how frequently you do?
CBC 1 month after starting and then every 3 months.
And every 3 months. Any other side effect that you look for?
You can get rashes. So sometimes vasculitis has been reported, and you can get rashes as soon as you start levamisole. Then you have to stop it. You can't use it.
Oh, you have to stop it forever. Okay, then
well, you can retry it again, but they often come up with the rash again.
Okay. So
just one thing, when you use levamisole, I think one of the things that pediatricians think about is that levamisole will treat relapses also. It won't. Levamisole, just because the child is on levamisole, if the child gets a relapse, you will still have to use steroids. And just because the child has had a relapse on levamisole does not mean levamisole is not working. If the child was having 6 relapses in a year, now it has come down to 2 relapses in a year, levamisole is still doing a job. So you don't discard the levamisole just because there is a relapse.
Understand. So how do you define a steroid-dependent nephrotic syndrome? And then again, what is the treatment? Is it the same or it differs?
No, the steroid-dependent is when they relapse on the tapering schedule of steroids or within 2 weeks of stopping the steroids. Now, these children are going to have a difficult course as it is. So levamisole may work in them, as I mentioned earlier, if those criteria are fulfilled. Otherwise, you'll have to use stronger agents.
Okay, so some alternative drug like an immunomodulator.
A small word of caution with levamisole.
Yes, sir.
A small word of caution that recent reports have shown that it can have an ANCA-positive vasculitis, which can be a serious complication, and we advise once levamisole is being used, at least after 6 months, get an ANCA test. it may not be positive, but I think with these reports, it becomes very necessary that we should keep that in mind, that it can cause ANCA positive vasculitis.
So
So
suppose
after
you
6
have
months,
Dr.
we get a ANCA
So
test.
Dr. Vasudev, your patient in levamisole is completely asymptomatic. As you said, you do after 6 months of PNCA and CNCA, it becomes positive, but he has no symptom. Would you stop or would you?
That's what we were discussing, and in AIMS, they had been doing some study, and they found that even when the child is asymptomatic, as is ANCA positive, it's a word of caution that we have to stop levamisole, because many of them may become symptomatic only later, but the biochemical test may come positive earlier. So I think it's very pertinent that we should keep that in
How
mind.
frequently do you see? I mean, Dr. Sushmita, have you seen levamisole-induced rash or a
We
vasculitis
have
syndrome?
we have just completed a study in Institute of Child Health in
Uh-huh.
Kolkata, which has been published already actually,
Mhm.
and the incidence is about 20%. And it is the ANCA positivity is seen more in children who are on prolonged levamisole. So really it is 6 months or more, as Dr. Vasudev said, those are
All
the
right.
patients that need to be tested.
Okay, I think that makes sense that you need to do some tests and look very carefully for those. Okay, what is steroid-resistant nephrotic? Now that's a completely different ball game. How do you now manage? Of course, I don't know any pediatrician who manage such a patient, but they should know when it is steroid-resistant, then what next is the nephrology going to do?
I think Fagun already explained that if there is no response to steroids in 4 to 6 weeks' time, then you label it as steroid-resistant nephrotic syndrome, provided the patient has taken the medication and there is no intercurrent infection at the time when you are seeing the child at
Can
6
you
weeks.
extend it by 2 more weeks of the full dose steroid and see whether at 8 weeks is the cutoff to say steroid resistant or 6 weeks is enough?
No, we used to say it at 4 weeks. We have extended it to 6 weeks. If they haven't responded in 6 weeks, there are some studies which show that they may go into remission later, but they usually have a difficult course later anyway.
Correct. What are the causes? I mean, which are the nephrotic syndrome which are usually steroid resistant? I mean, most of the minimal change are steroid sensitive, as we said.
90% are.
Yeah.
So there are other varieties. So then you'll need a biopsy in each one of them. So
correct. So what are the common types which you see in which
the
are
commonest one that we are worried about is focal segmental glomerulosclerosis.
Okay.
Because that has a
Anything
very
else?
poor prognosis. The mesangial-proliferative glomerulonephritis can also.
Okay. All right. So when would you do a renal biopsy in a patient of nephrotic syndrome?
In steroid resistant, all of them need it.
Okay. And
in steroid sensitive ones, if they are frequently relapsing and you're thinking about using third line medications, for example, cyclosporin or tacrolimus.
Does the age matter when suppose older child come with nephrotic? Are you more worried about steroid resistant or some other cause of nephrotic rather than MCNS?
So the classical period that we say is up to 10 years, but we do extend it to 12 years. And treat them with steroids and see if they don't respond, you anyway biopsy. But if they present beyond that, then they will need a biopsy before you start treatment.
Okay, so while, as I said, I don't want pediatrician to delve into treating such patient, but what are the general principles? I mean, what do? You use immunomodulators like what, rituximab, cyclophosphamide, plasmapheresis?
For which one? Steroid resistant.
Steroid resistant ones.
Steroid resistant, usually you would start them on tacrolimus or cyclosporin, and then depending on what the biopsy shows, then you're going to give the prognosis to the patient, because FSGS only 50% will respond to any medications. Most of the others will go into end-stage renal disease.
And what about cyclophosphamide, rituximab, those type of drugs?
Cyclophosphamide is more for steroid-dependent nephrotic syndrome in the initial part after levamisole.
And rituximab?
Rituximab is those who are doing poorly even on tacrolimus and cyclosporin. That is where we would be using.
What is the general outcome of this type of patient who are very frequent
Dr. Nitin, can I just add?
Yes, please. Yes, anytime.
Small point is that there are a lot of genetic causes also that are now being discovered of steroid-resistant nephrotic syndrome. So steroid-resistant nephrotic syndrome, which has not responded to the cyclosporin or tacrolimus, should definitely have genetic tests done, because we should not keep giving immunosuppressants to this group. They will not respond.
No, so what are the types of mutation which are common in them, and they need what, transplant, or they can be?
So they get, yeah, but Pankaj, you want to?
Yeah, they'll need a transplant because these they do not respond to any medications.
Okay, so in general, what is the outcome of these patients who are on
Steroid resistant.
cephalosporin?
No,
Yeah,
which
steroid
ones?
resistant.
Genetic ones, 100%
No,
will
not
need a
genetic.
transplant.
Steroid
The
resistant
steroid
as a
resistant
class.
overall as a group, in 30%
Yes.
of them, they will progress to end-stage renal disease. If you
Okay.
take FSGS as an entity, as I said, 50% will progress to end-stage renal disease, 50% will only respond to some medication.
Correct. And if you transplant them, is the transplanted kidney at risk again of the same pathology?
Depending, that's why the biopsy is important. So FSGS, 25% risk that it will come back in the new kidney.
Okay. Okay. And last, just one, we close the nephrotic syndrome because we have discussed for almost 40 minutes. And I think that's an important disease because pediatricians are day in and day out going to see this patient. And the last is there's something as congenital nephrotic syndrome. And I vividly remember one patient under you in Hinduja, hopeless outcome and very difficult to treat. Just few lines on what is congenital nephrotic syndrome and how difficult it is to treat.
Well, to say it briefly, it is basically genetic in origin. So you can have either syndromic or you can have genetic mutations causing it. So Finnish type, you have diffuse mesangial sclerosis, or you can have syndromic like Dennis-Drass syndrome and the other ones. They do not respond to steroids. They present in the first 3 months, but sometimes the presentation may be missed up to 6 months. So they usually present in the first 3 months itself, and they all will need a transplant eventually.
And if they are transplanted, suppose in time, do they survive for a very long time or again the same problem?
Yes, Finnish type nephrotic syndrome, if they do go ahead and get a transplant, they will do very well in the long.
Which is the youngest child of such a case who has been transplanted in the world literature or in Indian literature? 6 months, 1 year?
I think 6 to 9 months. No, in India, I don't think the transplantation is done unless they are 10 to 15 kgs.
Correct.
So you don't transplant them earlier.
Yes. Sushmita, you have any
I have seen children not in India but abroad transplanted when they're about 10 kg. So
10
by
kg.
about a year.
Have you done any such in ICH?
We have done about earliest is about 3 or 4 years.
3 or 4 years. All right. So I think that finishes.
So about 14 kgs or so.
All right.
So that finishes the discussion on transplanting children at after 10 kgs weight, and you have done it. Not these congenital nephrotic, and in congenital, I think most of the times Pankaj would agree, we don't even do biopsies in these children. We would go in for genetic studies rather than biopsy, which is more pertinent. And today a whole exome sequencing is cheaper than doing a biopsy. And a small suggestion for my pediatric friends that during relapses, during infections, many a times we see proteinuria, and if the child is immunocompromised, has received steroids of late, quite high doses, or is on alternate day steroids, we just make it daily for 5 to 7 days and prevent relapses once the child is having infection. So that is when the patient is on treatment. We had most of the time when the patient is off treatment, but suddenly there is 2+ proteinuria, parents are worried it's a relapse. And if there is history of recent infection, is a time you wait, don't be in a hurry. Correct? That's the
but the most important thing is
just make it daily. Fagun.
Yes, so the most important thing is that even after 5 to 7 days after the treatment of the infection, if the child is gone into remission, it is better to check or ask the parents to keep on checking at least for the first 2 weeks or so, because there are chances the child will relapse early.
Sure.
The second important thing is that in children below 1 year of the age group, if they are having a nephrotic syndrome, initially we advise to do a biopsy, but now as discussed that basically it is better to do a genetic testing in all these patients below 1 year of the age group.
All right. Okay. I think very vivid and very clear discussion nephrotic syndrome. I'm sure pediatricians are treating, but they'll be a little more wiser after this discussion, and they view this again and again as to exactly how much dose to give, when to stop, and how to monitor. We move to the next case, and Dr. Ramesh, will you take it with Dr. Sushmita?
Yes. So, Sushmita ma'am.
Yes.
Little louder, Ramesh bhai.
Yes. Now, this is a 10-year-old male child, and it was brought with complaints of not eating well. Parents want some general tonics. I mean, this was the purpose. But a smart pediatrician examines and finds that the child has grown well with weight of 30 kg and height of 136 centimeter. Systemic examination is normal, but because he is very meticulous, as a routine, he measures blood pressure also, which is 135 over 95. So now, how do you take blood pressures in a child? Position, cup size, NIBP? Please throw some light.
Okay, thank you. So the first thing to note is that a single high, obviously this is very high, this blood pressure 135/95. A single high blood pressure reading does not really mean very much. We need to repeat it to make sure that this is what we are getting in at least 2 more readings. When we are taking the blood pressure, we have to be very careful that the methodology is correct. The child should be at rest, and we can measure it in supine or in sitting position. And the antecubital fossa where the stethoscope is placed should be at the level of the heart. The cuff size should be correct. So that is something very important. If the cuff size is too small, then the blood pressure will be recorded very high, and vice versa. If it's a big cuff, then we will get a wrong low reading. So how to measure for the appropriate cuff size? We need to measure the mid-arm circumference, and the length of the cuff, which goes around the arm, should be 80 to 100% of that mid-arm circumference. So it should almost cover the circumference of the arm. The perpendicular width of the curve should be about 40 to 50%. And so that is the correct way to measure it.
NIBP.
NIBP, okay. So NIBP, when we are measuring, it is a oscillometric device. And oscillometric devices are not, most of the ones that we use are not validated for checking blood pressure in young children. Most of the machines that are available. And so, yes, it is good as a screening tool. It is very easy to use in small children. But if we get a report which is high, low, we have to cross-check by a auscultatory method.
Now, Susmita ma'am, as a nephrologist, you take blood pressure in all 4 limbs?
Not routinely. Routinely, we take pressure in the right arm. But if we find a high blood pressure, then we should take a 4-limb BP. If we take find a consistently high blood pressure. So if you look at the current AAP guidelines, it says do 4-limb BP in the second visit when you have confirmed the high blood pressure, if it is elevated BP group or if it is the stage 1 hypertension. But if it is stage 2 hypertension, then you should check all 4 limbs even on the first visit. But I think it's a non-invasive test to do. And if we have doubts of getting a high blood pressure reading, we should really make it a practice to check all 4 limbs.
So just to interrupt, Dr. Ramesh, I will like to tell one story here. One child came to me, the parents brought that the child is very thin and he's not like our family. There is something wrong. Please examine, give some vitamins. So as I always do for the first time, made a file and I took BP. So he was very, said, why are you taking blood pressure of this child? I mean, I just want some general. I said, no, it's my routine. So I took it and I was like sweating. It was 200/100. So I said, you make the child wait for 5 minutes. I will take again. Now he got a little serious. So he came back after 5 minutes. Again, I checked, it was very high. So I said, no, the child blood pressure is very high. We need to do some investigation. So he said, okay, doctor, I'll come back tomorrow. Next day, he came back with a diagnosis. Doctor साहब आपने left arm में नहीं लिया, उधर तो BP है ही नहीं. तो मैंने तो today को कराया, उसको coarctation है. अभी आप मुझे बोलो, where do I go for the coarctation surgery? So smart.
So if you go by the guideline, this is stage 2 hypertension, and it should be checked on 4 limbs right at the first
exactly.
visit.
So you'll get the, and but the question is, it was very rewarding for me that I took the BP. The parents were flabbergasted that I took BP, and I'll not believe we must have brought at least 100 more families to me saying that एक डॉक्टर पागल है लेकिन blood pressure देखता है.
The other thing for the general pediatricians to note is that all the current BP guidelines say that every child 3 years and above should have at least one blood pressure reading a year. So annual BP reading is a must for all children.
The major problem, practical thing is that most of the time child is crying, and so pediatrician is struggling in this situation.
So unfortunately, there is no shortcut. We have to pacify, we have to give patience. If required, we have to bring the child back on another day. It's nice to ask the parents to buy one of those, toy blood pressure machines. So maybe, practice with the child, let them play around with the machine so they are not scared about it. But there is no shortcut. We have to wait to have
The one way
Peaceful
you can
child.
do is, normally what we do is we just tie the cuff and let the child go and play with
let
the
it be.
mother and come back when the child is sort of half asleep, and then connect quickly and take, so that the child is not threatened by a machine which is being put immediately.
Yes.
Go ahead, go ahead.
Within one suggestion about the cuff size,
Yes.
most of us have a 5-inch cuff size. All pediatricians would have a adult blood pressure instrument, and they will not have small cuff size. So what I suggest them is that
No, sir, everyone has. In fact, at the vaccine CME just a month back, our delegate kit was not any stupid thing, but we gave them 3 different sizes of BP cuffs
So only
from the
one
organizers.
extra size of 3-inch cuff size, if they attach
Yes.
it to the 5-inch cuff size, they can manage 2 years to 18 years children with all types of blood pressure.
So we gave them a
just buy
neonatal
one
cuff, an
cuff
infant cuff, a 5-year-old child cuff, and a 10-year-old child who can take the adult cuff. So we gave them
adult,
3
I think
different
that's an
sizes.
excellent gift, excellent gift. Instead of giving
And I
bag,
think every conference
Yes.
should do that. That, you know, we had to indent it from Hyderabad by airfare. It costs us a bomb, but we said, no, nothing doing. We will give this because this is very important to take the correct BP.
excellent.
Yes, go ahead, sir.
Yeah. So Shweta ma'am, now how many readings, like physicians, they take 3 readings, and at what interval?
We should take 3 readings, all of them when the child is quiet. That is for each BP reading should be averaged from the 3 readings.
Correct.
But to stamp this as hypertension, we need to check on different days. So 3 different days also
Correct.
we need to check similarly
Correct.
before stamping. And
Correct.
that those 3 days should be within about 2 to 3 weeks. If it is elevated BP or stage 1 BP, stage 1 elevated hypertension or stage 1 hypertension, and it should be much closer definitely within a week if it is stage 2 hypertension.
So how do you interpret it? I mean, 120
So
over
what-
80 is as gold standard?
No
Or
way, no way.
some cases now?
So we have these very nice BP centile charts nowadays, which gives us, according to the age, the sex, and the height of the child, what is the normal centiles. So it will tell us the 50th centile, the 95th centile, and the 95th plus 12 centile, which is the stage 2 hypertension limit. So we have to read up what the reading we are getting. We have to look at the centile chart and see where it falls on that centile chart.
So one has to follow the chart. Now, is there any app?
So
for
if
the
I
use of
if I
pediatrician?
actually check BP in an older child and I get it 120 by 80, I never write 120 by 80 because then the patient will that I'm just bluffing. Write 118 by 81 or 82 or something.
So
Just
the
to
child
make it
is
more
over
authentic.
13 years. If it is over 13 years, the child, then we can take these
Yes.
cutoffs. So 120
yeah.
by 80 is elevated BP for a 13-year-old and
Yes.
above. And 130 by 80 is hypertension for a child who is 13 or more.
I think it's a dictum in our hospital. I'm sure it must be same true that any child who's admitted where a blood pressure is monitoring is required or is done, the 95th and 90th centile for the child's age and height are always put on the first page, so that when the sister takes, she knows when to alert you. So I think that's a good
Point. Yes.
Yeah, to follow. Yes.
So Shmita, now the common pediatrician is always puzzled with such centiles and all these words. So is there any app for the ease of?
There's an excellent app actually. If you look up MedCalc, and there if you put in the search engine, if you put in AAP, hypertension guidelines, you will get the app. All you have to do is put in the height, put in your systolic, diastolic BP and your age, and it will tell you whether this is normal, elevated, stage 1, stage 2.
Right.
So it is very easy.
There are some more apps, Dr. Ramesh Bajana. There is one Calculate app. There is one PEDS, PEDZ. All these have the similar thing what Dr. Sushmita said. They just need to put the data and you get the ultimate outcome. Yes.
But whenever you get the BP or centiles by this app, it is always prudent to always check also with your charts, basically.
Yes,
because you
it is
don't
prudent,
have
but this specific app is validated by the the group who did the guidelines. So I think this is a very useful app to have.
Correct.
Now, what is white collar hypertension?
So white collar hypertension, as the name suggests, is blood pressure that rises when children see us in our doctor's attire, stethoscope or white collar or lab coat. So it is hypertension which is detected in office practice. But if you did a ambulatory blood pressure monitoring over 24 hours, then the mean blood pressures would be lower than the 95th centile.
Okay.
So this is a stress-induced hypertension. But the concern is that even white colloid hypertension in the long term, a few of these children may develop real hypertension. So these children have to be followed up. Although we don't treat them, we should follow them up.
Correct.
And there are some cups without rubber bag inside. What about that?
Yes, some of the new machines, the fancy machines, don't have that rubber bag, but then you just measure the inflatable part of the cuff. So if you're not sure which the inflatable cuff is, you can just tighten the knob and blow it up a little bit, and you can see which part is inflating, and that is what is acting as the cuff.
This type of cups I saw at one of the conferences in Gujarat only. It costs around 2,000 rupees. They say it works for 3 to 4 years, definitely, but maybe longer. And the advantage is that, that rubber wears off, it leaks, all that doesn't happen. I mean, I don't know, I have not used it, but maybe look very fancy and look very, very.
Many of the new, the very expensive machines use those, and all your NIBP cups are the same.
Yeah, they are all the same.
If you look at the NIBP or your digital machines, they all have this. They don't have a rubber bag inside.
Okay, let's switch to Dr. Fagun now. This child has hypertension as his systolic and diastolic were above 95th centile on 3 different occasions. As Dr. Sushmita said, you should take average of 3 and on 3 different occasions, and all the time this was a very high. So when will you suspect that this is probably a renal cause? Because that's the commonest cause besides essential in a smaller child at least. So when do you suspect a renal cause?
So if we talk about the renal cause, as you rightly pointed out, that is the most common cause of the hypertension in our pediatric patients. And again, if we look at the renal cause of the hypertension, about 90% of the children below 6 years might have a renal hypertension, and even 70 or 75% of the patients between 6 to 12 years. So just you need to date back your history to the neonatal age group. Any children who are having a prematurity, long NICU stays, IUGR babies, because of the low recruitment of your glomerulus and a decreased number of the glomeruli, patients who are having a neonatal AKI or AKI any part during any time, patients with a nephrotic syndrome, post-infection glomerulonephritis, or patients who are having the microscopic hematuria or proteinuria, etc., patients with ambiguous genitalias, patients who are having some tumors, and most importantly, as you rightly pointed out, that you should always measure a 4-limb BP, and if there is a difference in the pulses, you might be dealing, or of the difference in the BP, you might be dealing with some of the aortic arthritis or the major vessel arthritis. Again, patients with a reflux or recurrent UTIs, PURs, some congenital Keckert, or patients with MCDKs, ARPKDs, all these are the conditions in which, or with any of the patient who are having a Keckert, there is a possibility, or most of the times we are dealing with a renal cause of the hypertension.
Yes, so the other two causes that you should not miss is, one is cardiac. We already said take a 4-limb, get an 2D echo done. Maybe in every patient with hypertension worth it, so you don't miss a co-op. And the other is essential. Now we are with the obesity setting in even younger children, as young as 8 and 9 years. We see many of them have borderline hypertension. So essential hypertension is going up. Have you seen it in your day-to-day practice that you ruled out renal cause in a little older child?
Yeah. So basically, if you look at the age group, if it is below 5 to 6 years, the chances of having a primary hypertension is little bit, or we can say it is almost extinct, and you need to find out a cause for the hypertension. But above 6 years, definitely you need to keep in mind, and there are certain pointers to it. Say, for example, there is a strong family history of the hypertension. 7 to 80% of the times there is a family history which is present, and the patients will have a history of hypertension in the younger age. These children will be obese, might have a syndrome X. There is no specific diastolic hypertension, which is very common in the patients with the secondary hypertension. Patients are asymptomatic. There could be dyslipidemia, impaired glucose tolerance. So all these are pointers, and your basic investigations are not suggestive of any other cause of the hypertension. So these are the conditions in which you might suspect a primary hypertension as a cause. And these are the patients which are very, very important, because this hypertension will always lead to a cardiovascular disease in the young adults. And we see a lot of patients who are now dying and having all this at a younger age group, and we don't know, because this might have an antecedent hypertension in the younger age group or in the adolescent age group, which we might have missed actually.
So I think we said that the pediatrician who missed Kawasaki, they hand over young myocardial infarct to the cardiologist friend. The pediatrician who mismanage renal issues in children, they hand over end-stage renal disease to the adult nephrologist as a young adult. That's very true. Okay, how do you investigate like such a child who is having hypertension? It's a small child, 10 years. It's not very small, but 10 years. Could be essential, could be cardiac, could be renal, could be anything. How do you investigate further? Everyone you investigate in detail, especially in a child?
No, first of all, I mean, this is an insidious, or we can say accidental hypertension, which has been detected by a smart pediatrician. So basically, if you look at the hypertension or the investigations which we need to do, there are 4 or 5 things which we'll do basically. The most important thing is basically the renal function, urine microscopy, and serum electrolytes, and we do need to do ultrasound examinations, because most of the times, and of course echocardiography, because this will also tell you the coarctation of aorta and whether the hypertension is long-standing or not, because because you might have an LVH or a left ventricular mass. Most of the times with this, you will be able to spot out what is wrong or what we are dealing with. But however,
so when you do the ultrasound for KUB, you also add Doppler along with that always, or?
So what are you going to do Doppler for? If you are really thinking in terms of the renal hypertension because of the renal stenosis, it is fine. But let me tell you that I haven't seen any Doppler which is picking up a renal stenosis in a patient's, or at least in this younger age group. This is because that most of the times the renal stenosis in our pediatric patients is mainly because of the fibromuscular dysplasia, which can occur in the small branch vessels. So these branch vessels are not easily picked up by the Doppler. That is number one. And number two, you need the child to be very calm, because it requires a lot of patience on the part of the ultrasonologist to have a Doppler study and to pick up these things. So most of the times, renal Doppler will not have any yield. And if you are really thinking of that, do a angiography.
Correct. And what about role of plasma renin, selective renal?
So plasma renin, again, it is not an important investigations. It is not very sensitive. It might be falsely low. So you don't waste money in that basically. And most of, as I told you, that if you are suspecting it, better to do a angiography.
Renal angio.
Renal angio and final exam.
All right. Now the question, suppose the child has renal artery stenosis on one side. That's the cause of his hypertension. How do you manage the hypertension and how do you manage the renal artery stenosis?
So, like, you need to go for a non-pharmacological therapy and the pharmacological therapy. We all know about the non-pharmacological therapy. As far as the pharmacological therapy is concerned, there are 4 or 5 drugs which are most commonly used. And if I label these 4 or 5 drugs, one is the calcium channel inhibitors, one is the ACE inhibitors or ARBs, then the diuretics, and finally we have the beta blockers. Then we have the other list like the alpha agonist and alpha 2 agonist and alpha blockers, etc. But it is very, very important to see what we are dealing with. Say, for example, if we are dealing with renal artery stenosis, I will be a little bit more cautious while using an ACE inhibitor, because though it is on the one side, there could be a fall in the GFR, and especially you are having a bilateral stenosis, you never use it. Again, if you're dealing with a patient who are having a glomerulonephritis with a hyperkalemia, you definitely never use a ACE inhibitors, but the most important choice will be a CCBs. On the contrary, if there is a cardiomyopathies and if the GFR is good, you will definitely use a ACE inhibitors along with the beta blockers. So the choice always depends upon what you are dealing with. And if it is very, very important to start with one drug, go to the maximum level of that drug, tolerated maximum level. If the child is not improving, then you add on the second drug. Don't always try to jump between multiple drugs.
And ultimately, treat the cause would be the ultimate
treatment of the cause, because in our pediatric patients, we need to find out the cause, because majority of them are having a secondary hypertension.
Correct. So all patients who have hypertension and are found to have renal artery stenosis are subjected to surgery, and what type of surgery?
So unfortunately, we don't have much guidelines of how to treat these patients, but basically patients who are having a unilateral renal artery stenosis in a single kidneys or a bilateral stenosis with a good kidneys, receiving multiple drugs and uncontrolled hypertension, having cardiac issues in the form of increased left ventricular mass, cardiomyopathy, attacks of left ventricular failure. All these are the patients who definitely require surgery. Most of the times it is basically an angioplasty with a stent insertion, or very rarely a revascularization surgery.
Okay, fine. I think so. Hypertension by itself is a discussion for 2 hours. We cannot discuss the antihypertensive drug because we are discussing today nephrology. So the nephrology part of hypertension will be discussed. And now let's move to the last case. We have 20 minutes. Dr. Ramesh, would you take it with Dr. Pankaj? You continue? Okay. Pankaj, so let's have the last case for today. A 4-year-old male child has sudden onset of blood in the urine for 1 day, passed for 3 to 4 days. So 3-4 days he's been having fresh blood in the urine intermittently. So in between, the mother said the urine is clear, but sometimes it is a bloody red. There is no pain, there is no burning, there is no frequency, there is no puffiness, no edema of feet. There has been no significant family history or past history in the child. The child is otherwise well grown and otherwise normal. Now, does the depth of redness of the urine correlate with the amount of blood lost in the urine, or there is no correlation?
You just need a few drops of blood in a liter of urine to make it look completely red.
Okay.
So that doesn't
How do you know it is hematuria versus hemoglobinuria versus myoglobinuria versus none of them and some dye or color and things like that?
So I think on gross examination, bright red usually is hematuria. Dark is hemoglobinuria or myoglobinuria, but on your
that testing, is smoky urine as they call, or the cola colored urine. Okay.
Yes. And but as we discussed last time in our nephrology meet, so there are three things you need to remember. If you've got red urine with plenty of RBCs, it is hematuria.
Correct.
If you have red urine with no RBCs but occult blood 4+ positive, it is hemoglobinuria or myoglobinuria. If you have clear urine with occult blood positive and RBCs less than 5, then it is pseudohematuria to be ignored.
Perfect. Perfect. And what is the color of urine in acute glomerulonephritis? I mean, we should see that in past. Why is not it smoky?
Textbook describe coca-colored urine and tea-colored urine and everything.
Correct, correct.
So, but the common presentation of, let me tell you, the people who present are usually having clear urine, because microscopic hematuria in acute glomerulonephritis has a more severe presentation.
No, that I understand. That's on a follow-up you would want to really look into. Yeah.
It looks brownish because there are a few RBCs which extrude through the membrane and get hemolyzed, and therefore it looks darker. And
so it's both hematuria and part of hemoglobinuria, which is making a very peculiar color. All right. Okay. Can vigorous exercise by itself lead to hematuria?
Yeah, it's rare. And so the first thing is it is rare. Secondly, it is a diagnosis of exclusion by ruling out all other causes. And when we say vigorous exercise, it is really vigorous exercise. So if you look at adults, they talk about running 6 miles, and then you will probably get it in some patients. So yes, it can happen, but it's not very common that you will be seeing it often in the clinic.
So you said that you have ruled out other causes. So what are the other causes of gross hematuria?
Right. So if you see red colored urine in a patient who's coming to you, the simple way to go about it is I'm not going to go through the exhaustive list, but think about lower urinary causes. So a urine infection where the child will have symptoms of the same. Correct. Secondly, the child can have a kidney stone. Again, this child does not have pain. When I say a stone, again, that is 2 hours. That is 2 hours of talk itself, but ultrasounds which tell you 1 millimeter, 2 millimeter calculi sitting in the calyx cannot cause red colored urine. Correct. So let's forget about those. So ureteric calculi, when the calculus is coming down, you will get red colored urine. But that is associated with symptoms, or you can have other causes like tumors. So these are lower urinary causes. And if these are not there, then you need to start thinking about the kidneys and glomerular causes. The common one which we know is post-infectious nephritis, but be aware there are other causes like IgA nephropathy, where your own immunity is attacking the kidneys and therefore you get hematuria.
Correct.
Thin basement membrane disease, you can have Alport's disease, you can have mesangial-proliferative nephritis, and apart from post-infectious nephritis, none of these have got as good a prognosis. Correct. So these have to be looked at. Yeah.
Okay, so now this child's urine was done. It shows blood 4+, packed full of RBCs. There are no casts. So it's a proper hematuria. Now, in such a child who is otherwise asymptomatic, what are the things that you should keep in mind before ruling out that, okay, we'll wait for the next episode?
No, all these conditions that I talked about, I think the answer becomes clear if I tell you what happens to these conditions that we talked about. So if you take IgA nephropathy, out of all the patients, 30%, so these children can either have repeated episodes of gross hematuria or persistent microscopic hematuria. 30% of them throughout life will lead a perfectly normal life. 30% will have kidney problems coming up in 10 years' time. And 30% will have kidney problems coming up 20, 30 years down the line.
Correct.
And though the ones who you can predict or ones who are going to develop these are the ones who are going to develop proteinuria, hypertension, or an abnormal creatinine. So that is what needs to be monitored in these patients. So you need to get an ultrasound to look for lower urinary causes, and you also need to get the CBC for clotting and all that. But apart from that, for the kidney part, you need to get a creatinine, a blood pressure, and a protein creat ratio. But don't do a protein creat ratio when the urine is red.
Blood,
do it when the urine clears up.
Correct, perfect. So now this child BP is...
Yes,
Vasudev.
Yeah. I think once we get blood and we have seen there are RBCs, I think we can see for glomerular versus non-glomerular, that will differentiate between the lower and the upper tract hematuria. And then we can go on for further investigation depending upon whether we have dysmorphic RBCs and there is non-glomerular or glomerular hematuria.
Absence of dysmorphic RBCs does not rule out glomerular.
Rule out glomerular disease. Okay. So proteinuria is the first indicator of a glomerular disease. Am I correct?
Yes, but it can come now or it can come up
later.
6 months later. So the important point is that these children need to be monitored irrespective of whether they are getting repeated episodes of hematuria.
Perfect.
Because they may just have persistent microscopic hematuria.
Perfect. So this child BP is normal. Systemic examination is normal. Locally, there was no meatal injury or any such thing. There was no history of trauma, of course. There was no history of using NSAIDs like ibuprofen in the past. Urine has shown no cast, as we said. The ultrasound was done, which is normal. Creatinine is normal. His CBC and a bleeding profile, including PT, APT, is normal. Sickling test was done, which was normal, and a C3 was normal. Now, this child has absolutely nothing except one single episode of painless hematuria. Now, do you always follow them up with protein creatinine ratio and a microscopic hematuria? If yes, how long? Or you would wait for another episode of a gross hematuria or visible hematuria, then to make you do the follow-up test, and for how long?
That is the reason I told you what happens to the condition. So I just told you about IgA. So these patients can have problems 10 years later. So you will need to follow these children up. So an annual creatinine, a blood pressure, and a protein creatinine ratio is required in these patients.
So suppose for the first, suppose this time is normal, after 6 months normal, after 1 year, after 2 years normal, you keep on doing it for like lifelong?
Well, I advise normal people also to do a creatinine and blood pressure once a year along with the protein creatinine ratio. So we are not telling anything different from normal person anyway.
Okay. All right. Now, what is this post-micturition bleeding in boys? I mean, is it that common or it's rare?
It's not. The terminal hematuria is the word that is used. If you were in Africa, schistosomiasis becomes one of the diagnoses. In India, you do see terminal hematuria. It's often because a blood vessel in the trigone has been affected, has been damaged either by viral infection or whatever, and therefore after they pass urine, you'll get 1 or 2 drops of urine.
Correct. But is it benign or it is, and can it be recurrent?
No, it can happen. I don't think it's recurrent as such, but it's generally benign unless there is an infection which you need to treat. If there's a bacterial infection, you treat.
Fine. Two things. You mentioned about IgA nephropathy. So how do you investigate further for that to prove there's IgA nephropathy? Like suppose the child on follow-up has microscopic hematuria and proteinuria persisting.
Biopsy. The only way to diagnose IgA nephropathy is a kidney biopsy. All other tests are circumstantial evidence. They don't really tell you whether there's IgA.
And if you find there's IgA nephropathy, you treat them with immunomodulators?
No, IgA nephropathy, as I said, if you're going to do it in the stage where the child has no symptoms, has no meaning because you're just giving a label but not doing anything for the child. If the child has proteinuria, yes, you will need to do something. So you would start off, if there is nephrotic range proteinuria, with steroids. If there's non-nephrotic range proteinuria, we'll start with ACE inhibitors and then go along with what happens.
Okay. So irrespective of treatment, the outcome remains the same? No, or you can prolong?
No, if you can suppress the proteinuria, see IgA inflammation, if you can suppress and the proteinuria disappears, the long-term outcome improves.
So is it that you just delay the ultimate?
No. If the proteinuria disappears and they don't get it again, they will never have kidney problems.
All right. What about hypercalciuria as a cause of microscopic or gross?
It usually causes microscopic hematuria, not very commonly gross hematuria. So it could be one of the causes, but 5% of the normal population tends to have hypercalciuria.
So how do you then further investigate a patient suspected to have hypercalciuria?
24-hour urine calcium. Urine calcium creatinine ratio unfortunately does not give as good results as a urine protein creatinine ratio. You need to do a three samples of urine calcium creatinine ratio, but the better one is to do, if it's an older child, do a 24-hour urine calcium. If it is more than 4 milligram per kilogram per day, then it is hypercalcium. All
right. So we come to the last part and we are very in time. We have another 10-15 minutes to go. Dr. Sushmita, what about persistent microscopic hematuria? We discussed with Dr. Pankaj the macroscopic or the gross hematuria. Now, what about persistent microscopic hematuria? Does your approach differ then from a gross hematuria?
I think the crucial word is persistent. If it was transient, that is, you just detected it during a time when a child had fever or something like that, and it settles down, then it's not so important. But if it is persistent, that means if it is persisting at least on 3 investigations over 3 weeks, then it is something that needs to be followed up and investigated.
So which means one urine routine done for some reason of the child illness and it shows microscopic hematuria, you do at least 3
repeat, at least a repeat.
How frequently? Once a week?
So within about 3 weeks, you should have 3
Three.
Yes.
And if all the three show that there is microscopic hematuria persisting, then you need to investigate further. Correct?
Yes, just one point to make is that previously it used to be said that microscopic hematuria, if everything else is normal, if there is no other symptoms, blood pressure, creatinine, your basic investigations which have already been mentioned, like your serology, your ANA, all that is normal. Previously, it used to be said that you only go further with investigating if there is a significant amount of proteinuria. But very recently, that has changed a little bit, because now it is being shown that even minimal proteinuria in something like IgA, where your protein creatinine ratio is about 0.2, if you treat those patients, they do better. And more importantly, the guidelines for Alport syndrome have changed. In Alport syndrome, especially the X-linked type or the autosomal recessive type, we are now supposed to start treatment as soon as the diagnosis is made. So, and that the studies show that if we if we intervene early, we can improve the outcome significantly. So therefore, the importance of making a definitive diagnosis in every case of persistent microscopic hematuria becomes more important now.
So do I understand that I learned that if a patient is asymptomatic but has a microscopic hematuria on one sample, you have done 2 more samples weekly or whatever time, all the 3 are showing that, plus or minus proteinuria, you need to investigate further for Alports and IgA and other things.
And first of all, you exclude all the common things.
Yeah, of course.
Such as you exclude all those stones, UTIs, SLE, and glomerulonephritis, bleeding diatheses, sickle cell. So you exclude everything. But if it is persisting, then according to current guidelines, we need a definitive diagnosis. If there is family history, then the diagnosis goes more in favor of Alports. So then if your economics allow, then you do a genetic test.
Correct. Okay.
If there is no family history, then according to current guidelines, it is better to do a biopsy early rather than later.
So suppose you have done your
Alports, you would intervene.
Fine. So you have family history is negative, you have ruled out IgA, you have done a kidney biopsy, now everything is normal. What will you label this as? Just an asymptomatic persistent microscopic hematuria?
So why would it be normal? We would find something, right? If it is a glomerular cause, so
how will you know on a microscopic hematuria alone whether it's glomerular or non-glomerular?
The same things that Dr. Vasudev said, you look at dysmorphic RBCs, crenated RBCs, look at proteinuria, look at other blood pressure, etc., etc.
So are you trying to say that there can never be a clinical scenario where a child can have recurrent or persistent microscopic hematuria where everything else is normal and is otherwise normal child?
I think before you do a biopsy also, the final thing to exclude is small stones. So sometimes you can get a very small stone in the ureter which is not picked up by ultrasound, So there are, if there is persistent microscopic hematuria, there will always be some cause. It may not be in the kidney, it may be somewhere in the urological tract, but there will definitely be a cause somewhere.
Yeah, I remember whenever we have clinical meetings and Pankaj is around, people always get a little alerted about protein creatinine ratio, and he will always say that you have a suspected post-glomerulonephritis. Don't wait. The symptoms are okay, child is okay. Follow up with urine routine. So how frequently you continue to do urine routine if there is a persistent microscopic hematuria? Like how long? 3 months, 6 months before you say now we need in a post-stroke glomerular. Yeah.
So post-GN microscopic hematuria can continue almost till a year. But then you have different time levels for different things. So your macroscopic hematuria should clear up between 3 to 4 weeks. Proteinuria should clear up within a month. Your C3 should normalize by 3 months. And then the last to go is the macroscopic hematuria.
And that up to 1 year.
Up to 1 year. And if any of these timelines are not being met, then you have to think, is there something else going on? Do I need to do a biopsy?
So which means you would probably do a biopsy?
Yes.
To see for some other sinister disease.
You would have, by this time, I think you would have done your test looking for SLE and other ANCA vasculitis, etc. If all of it is negative, you don't get any clues. There are several glomerulonephritis which you cannot detect other than by a biopsy. So then you have to go ahead.
I think I'm going to reiterate this for the delegates. What Dr. Sushmita has been saying, what Dr. Pankaj has been saying also in the past is that if you have a suspected post-streptococcal glomerulonephritis like picture, patient become asymptomatic, gross hematuria disappears, that's not the end of the story. The end of the story is that, as they say, the gross hematuria should disappear within 3 to 4 weeks. Proteinuria maybe in the next 1 or 2 months. Microscopic hematuria at the most up to 1 year, but maybe a little earlier. And if these guidelines are not met with, you need to rule out other causes of glomerulonephritis or other renal disorders, and you would investigate further for other vasculitis syndrome, etc. If all is negative, they would ultimately need a biopsy before you put to rest this patient. So I think that is very important message, that it's not the end that the clinically child is okay, puffiness has disappeared, urine has cleared grossly, the child is okay. We should not do that. All right.
And also, even if they become okay, even then we need to follow up yearly, as Pankaj has said.
Absolutely. Now, before we end, there are two more things that while I was reading to make this question, and I was really intrigued by the terminologies used. One is a renal nutcracker syndrome. I had known an abdominal nutcracker syndrome where you have a kinking of the superior mesenteric artery because of obesity, and that leads to severe abdominal pain. In fact, I know one of my very close relatives' child had that, and all that we had to do is to make the child lose weight. So, what is renal nutcracker syndrome? What get kinks there and why?
Similar, it is the left renal vein which gets kinked between the superior mesenteric artery and the abdominal aorta. So because of this compression, there is venous engorgement, and usually it presents with recurrent macroscopic hematuria.
And they get pain also, abdominal pain?
Sometimes.
Yeah. And the treatment is?
So the treatment is, first of all, diagnosis. And then you have
so how do you diagnose? Diagnose based on?
If it can be diagnosed by a very expert ultrasonographer. But if you have if it is not picked up by ultrasound, then you might have to do a CT-angio or a MRI.
CT-angio. All right. And how do you treat it? You said like.
If it is causing major problems, you have to do. You have to
anatomy correction.
Correction or vascular surgeon.
It's usually seen in the pubertal age group.
Correct.
As the growth occurs, the hematuria stops.
Okay.
Very often.
So this is similar to the nutcracker in the superior mesenteric artery itself, which also is in adolescent, young, obese, sudden increase in the weight, and they lose weight and they grow, they become okay. Same thing here. All right. The last question before we end today's discussion is: I also heard something known as thin basement membrane disease. What is this thin basement membrane disease? Does it cause of microscopic hematuria?
Thin basement membrane disease, the terminology as a diagnosis has changed. So we used to call this as a condition in which you had your basement membranes were very thinned out throughout, and you would get a sort of a familial autosomal dominant pattern of recurrent macroscopic hematuria with intermittent, in between maybe microscopic hematuria. But nowadays, and the difference from Alport's was that you would not get extrarenal findings like deafness, eye changes. But
unlike the other vasculitis syndrome.
But now this thin basement membrane disease is recognized as part of the spectrum of Alport syndrome. So this is also due to collagen 4 gene mutations similar to Alport syndrome.
Oh, I see.
So Alport
but the
syndrome,
prognosis is different?
It's a milder form. So Alport syndrome is either due to the X-linked type or autosomal recessive type, where you have 2 genes which are abnormal. Whereas this condition, it is a heterozygous mutation. So only one gene is mutated. So it is a milder form, but it is those collagen genes, A3, A4, and A5, the collagen 4 genes, which are mutated even in these.
And what do you do to these children if you diagnose one?
So these are genetic syndromes. They are not going to improve really with much. You give them very maximum supportive treatment. And as I have previously said, that most of these patients now are treated very aggressively right from diagnosis with RAS inhibitors. So, captopril, ramipril, lisinopril, enalapril, these kind of agents, even before proteinuria sets in. So generally we think that we give RAS inhibitors in kidney diseases which are associated with proteinuria, but in Alport spectrum, it is now advised, especially for the X-linked and the autosomal recessive types, that treatment with RAS inhibitors are started at diagnosis. And this can delay the onset of gross proteinuria, renal failure, etc.
Again, this will be a renal biopsy diagnosis, or is a genetic diagnosis?
A bit of both. So renal biopsy, if you did to diagnose Alport's or this condition called which used to be called thin basement membrane disease, you'd need to do electron microscopy, which is not so easily available in our country. But nowadays we can send tissue to a few centers that do it. But genetics is the final confirmatory diagnosis.
Okay, I think that marks the end of the set of questions that I have. You have any remarks? Because we have 5 more minutes.
I just
Dr.
wanted to,
Anand Vasudev first.
Yeah, I just
Yes.
wanted to share my experience
sir.
for one of the
Vasudev, sir.
patients which Dr. Pankaj was telling, that I had a young boy about 10, 12 years old who had come from Kanpur with recurrent episodes of gross hematuria. Almost all investigations done were normal, including CT to rule out nutcracker syndrome also, everything normal. Then I sat with the parents and the child, and the history was that the child was an avid football player. Whenever he played football for 2 to 3 hours in school, after that evening he would have hematuria, which would settle in 2-3 days time. And then he asked, if you play for half an hour or 1 hour, he says it doesn't happen. And it was a diagnosis of exclusion that it was basically an exercise-induced hematuria. And once his football playing reduced to smaller gaps, I mean half an hour, 1 hour, he was perfectly fine and no other cause was found. As Pankaj said, that's diagnosis exclusion. Sometimes we have to continuously take the history. They did not give this history. I had to find out because I could not find any other cause for the hematuria.
Fine.
Nitin bhai.
Any closing remark by Dr. Fagun Shah, Dr. Pankaj? Yes, Ramesh bhai.
Nitin bhai, in between, we invited Dr. Somsekhar sir, who is the president of Bangalore Pediatric Society. He was 10 minutes late. So, Dr. Somsekhar sir, are you there? Hello? Somsekhar sir, unmute yourself.
I think probably.
Yeah. No. Meanwhile,
okay. Fagun, any last remarks? Dr. Pankaj, last remarks.
Yeah,
Somsekhar is there. Somsekhar.
Sorry, sir. Good evening, Dr. Ramesh sir. Nitin sir, Vasudev sir, and it was really good. Enjoyed. Thanks for the invitation, and really acknowledge all the panelists for this wonderful talk. Thank you, sir. Thanks. And best wishes from Bangalore Pediatric Society.
Thank you.
Thank you, Somsekhar sir.
Fagun, last remark. And then
So basically, like Dr. Pankaj said, that most of the times what we are dealing with in the pediatric nephrology is the proteinuria, which is an harbinger of the renal injury. So in all these patients who are having any sort of renal issues, the most important thing we need to monitor is the kidney sizes, the protein creatinine ratio, the creatinine, and the blood pressure annually, because most of the times this will help you in dealing or catching up the things quite earlier, and institute a proper action at the right proper time so that we can delay the progression of the disease. And I just wanted to make a point regarding the asymptomatic hematuria also. So if we take into consideration the asymptomatic hematuria, we can just, or microscopic hematuria, we can just divide it into 2 things. One is the proteinuria plus or proteinuria minus. So if there is a proteinuria minus, I think so there are 3-4 conditions which are only there. One is a resolving phase of a post-infectious GN, one is an IgA nephropathy, or a hypercalciuria or a thin basement membrane disease. Don't do anything of these patients, just monitor for the creatinine, blood pressure, and protein creatinine ratio. And 60% of them will resolve in 6 to 9 months. If it is not, and if it is progressing off, there is a development of proteinuria, we definitely need to investigate. But in all the patients who are having a proteinuria with asymptomatic microscopic hematuria, it's a red flag sign. Early referral and biopsy is a must in all these patients.
Perfect. I think that says all. So, Dr. Pankaj, we have been talking about the protein creatinine ratio and that it's one of the important causes of damage to the remaining nephron. How do you treat?
Depends on the cause. So if it's a glomerular cause like nephrotic, you'll have to treat the inflammation. Whereas if it is hyperfiltration or it is Alport spectrum, as Dr. Sushmita said, ACE inhibitors would be the primary line.
Okay, fine.
So just one more point that I wanted to bring out to the pediatricians, especially hypertension that we talked about. If everything else is normal and the ultrasound is normal, that does not mean the kidneys are normal, because the DMSA scan sometimes shows abnormalities. Usually dysplastic kidneys present with polyuria, they don't become hypertensive, but some of them will present with only hypertension. and it will be picked up only on a DMSA scan, not even on a CT angio.
And if you have a situation where you have a one-sided dysplastic kidney with very little function and hypertension, would you want to surgically remove it, or
not? Unless it has zero function, you won't take it out. If it has good function, you would keep it. If it the borderline 5%, if it is uncontrolled hypertension, you would probably consider taking it.
Okay, fine. I think with that we come to an end to this very exciting part 2 of nephrology in pediatric with our allied panelists, Dr. Fagun Shah, Dr. Pankaj Deshpande, and Dr. Sushmita Banerjee. We had an expert, Dr. Vasudev, today also joining us. Of course, last time also he was there. Over to Dr. Ramesh Bajane to conclude the session.
So thank you so much, Dr. Fagun Bhai, Dr. Pankaj Bhai, Dr. Sushmita ma'am. I mean, I'm very sure that the viewers really enjoyed, because the questions were prepared by Dr. Nitin Bhai, considering them into mind. So be there on 12th September for our next webinar, which is Pediatric Vaccinology Part 2. I mean,
yes,
that is going to be another academic bonanza. So I thank the members of Gujarat Pediatrician WhatsApp group for being always there, very self-disciplined group. Dr. Nitin Shah, who is the pillar of this group since beginning, is a scientific convener. And we started in 2016 in a text form, and now it has grown to full-fledged webinar format with huge viewerships. And I'm so happy that Dr. Nitin Bhai has maintained the quality of academics to the highest level. Thank you so much. Good night, everyone.
Thank you. Good night, everybody. Bye-bye.
Thank you. Good night.
Thank you. Good night. Thank you.